Lecture is from Dr. George Jallo. Dr. Jallo doesn't need introduction to the Listserv community and to pediatric neurosurgery. He's the he's the vice chair at the Hopkins All Children's Hospital and the chief physician. Obviously, he's a neurosurgeon with a distinguished career, and he's going to uh, give us a talk on controversies in Chiari, pediatric Chiari. Um, Thank you, Dr. Jallo.
Naren, thank you. And hopefully everybody can hear me and see the presentation
Absolutely.
as well. And as Naren stated, I really just want to share my thoughts on Chiari malformations and some of the controversies surrounding this entity. For disclosures, have none to declare. And really, I'll start off with an illustrative case that I had to manage about a year ago. It's a 14-year-old girl that presented to the hospital with fevers and some lymphadenopathy. You can see the CAT scan there. And the concern was that she had mononucleosis. However, the radiologist astutely read a Chiari malformation on this CT scan with a syrinx. During her hospitalization, the MRI was performed, and you can see the MRI there. Clearly, the tonsils are below C1, and she has a cervical syrinx from about C2 down to C4. There's no evidence of tethered cord on the complete spine imaging. On examination, she was asymptomatic, no headaches, no visual complaints, no gait instability, sensory, or any motor deficit that was appreciated. And does appreciate all the lymphadenopathy that she has. And I did see her in the hospital. And given that she had an acute viral or syndrome, recommended really just to follow up in the clinic in several months' time. And we'll discuss the management uh, in terms of what would someone recommend. Would you recommend surgical intervention, observation? If it is observation, how often would you follow her? My recommendation initially was to come back in 3 months with a repeat imaging study. So really, there's some concerns and questions whether, is it a malformation or is it deformation? I think we heard a little about this in Dr. Limbrick's lecture. What is the etiology for the hindbrain progression? I think, the subsequent lectures discussed this. Is there a concept of supratentorial crowding, small posterior fossa? And in terms of treatment modalities, is there a single algorithm that best manages this entity? And I think, in terms of natural history, just sharing again the contributions that Hans Chiari had in the 1800s regarding the diagnosis of this condition. We had a great lecture on radiology, as well as some mention of this. As I was reviewing the literature on this, and the definition, the radiographic definition of the Chiari malformation. I think the first papers I was able to identify were in the mid 1980s, 1985 and 1986. And really, in the first paper, it's recommending that MRI is the diagnostic modality of choice to identify a Chiari malformation over CT, X-ray, or at that time, pneumoencephalograms or CT myelogram. And I think really astutely at that time, the radiologists recommended that the symptoms of Chiari can overlap those of a demyelinating disease. Interestingly, this is the paper that defined the descent of the tonsils as a Chiari malformation rather than physiologic or ectopia. And again, it was really based on 0.15 Tesla magnets. And clearly, we've come a long way since that time. And in this paper, really, what they found was that In the exceptional case that the normal position of the cerebellar tonsils may be 3 millimeters, and borderline cases are somewhere between 3 to 5 millimeters below. However, tonsils below 5 millimeters most likely suggested a Chiari malformation, and that really invasive radiographic techniques such as CT myelography was no longer needed. So, I think what are some of the appearances on MR? And, we did, this was really well presented in the previous lecture with the peg-like appearance, effacement of the CSF, a flattened occipital bone, venous engorgement, the tentorial slope, as well as the occipital lobe, being posterior to the cerebellum, as identified. And in terms of the pathology, clearly, the tonsils are typically below the foramen magnum, and very unusual. I think it's rare. I don't have an exact incidence where you tend to see the tonsils below C2. And then the associated hydrocephalus is uncommon. However, there is the associated abnormalities of the skull base, basilar invagination, and that syringomyelia, as well as scoliosis, can be found in this population. So the first controversy, and I'm so glad to see Professor O'Toole here, is this: is it a malformation or is it a deformation or a formation? I think we all should um, read his editorial in 2017, changing where he advocated for changing the name from a malformation to a formation. And Professor O'Toole, I think you can comment, but really, I think that the theory behind this is that congenital malformations are structural or functional anomalies that occur during intrauterine life, and that these conditions develop prenatally and may be identified before or at birth, or sometimes later in life, and that these malformations do not grow or progress, whereas a deformation or formation, on the other hand, is an action or a process of deforming or distorting a structure or its shape, including flattening or elongation, and that they can be a result of external forces over a period of time, and these deformations can be progressive, stable, or regress as the forces that act on the structural change. And clearly, I think that is the case with these Chiari malformations, is that there's a change. Some do remain stable, other progress, and others regress. And we've all seen that, and we've seen the papers regarding this. So should a Chiari malformation be termed a deformation? And knowing that the cerebellar tonsil descent through the foramen magnum is not congenital, and that and if congenital malformations are static and not progressive, should we redefine the terminology used to describe these? And I will leave that open for discussion at the completion of my presentation. And so what are the possible causes? Could it be the supratentorial crowding, that the tonsils are that it's not that they're growing taller, but they are being pushed down or stretched thin from above, and this is in the presence of the small posterior fossa. And I think others have recognized this as calling it a Chiari malformation 0, and or the Chiari malformation 0.5. And then is the Chiari deformation or downward stretching of the posterior colons, is that the presence, and the other is the small posterior fossa that's associated with some of the other skull-based anomalies such as basilar invagination, platobasia, cervical instability, and then ventriculomegaly. We heard from Dr. Christian about hydrocephalus and Chiari, and it's really what causes what. Does the Chiari cause the ventriculomegaly? Is it the descent of the tonsils that leads to an obstruction of CSF and an obstructive hydrocephalus, as well as a potential blockage of the foramen magendium or is it that that they're both in play, and it's a potentiating cycle? I think there are several papers that were mentioned. I think the most one of the recent papers that shows that that children with hydrocephalus or ventriculomegaly and a Chiari should be treated, as we heard earlier, with a CSF diversion rather than the Chiari decompression first. And clearly, in this recent paper, what they found was that the success rate for their series of a dozen patients was close to 93%, and that overall the length of the syrinx did not change. However, the diameter of the syrinx did improve, as one would expect if one completed a Chiari decompressive surgery. The other is in terms of, I think the diagnosis and the management and the presenting symptoms. I think this is a paper from the Oxford group on a review and really sharing their thoughts in terms of the symptoms, whether they were the general symptoms. They broke them down in general, which were like headache, cognitive fatigue, ocular symptoms, otoneurologic, such as dizziness, disequilibrium, pressure sensation, hindbrain symptoms, spinal cord symptoms, and you can see the relative incidence of these symptoms in their series, and in their algorithm, they really presented an algorithm for the primary care or the neurological physician in terms of making the diagnosis and the treatment algorithm or the diagnostic algorithm. I think this paper really summarizes the presenting symptoms. I know Dr. Limbrick spoke about this, whether it's the headache, fleeting headache, neck pain was probably the most prevalent in as a presenting symptom, scoliosis, and then the sleep apnea or bradycardia was seen in about less than 10% of their series of the review series. So, changing gears, what is the outcome? And I think Dr. Lemprick did discuss there's really no paper that shared the long-term natural history of a Chiari malformation. However, from the DC Children's Group, they looked at some incidentally discovered Chiari malformations and which individual child or a pediatric patient required closer observation or the need for surgical intervention. And as one expected, if there was the presence or absence of a syrinx warranted were typically operated. If a syrinx was present, almost close to 100%, 94% of the children at some point within their study follow period of about 10 years underwent surgical intervention. Whereas if a syrinx was not present on imaging, the chance of the likelihood of intervention was probably less than 5%. And they also looked at the extent of the tonsillar herniation or descent, whether it is between 5 to 9 millimeters or more than 10. And there really wasn't a statistical significance in terms of how low the tonsils were for the future need of surgery. So clearly, in their review, they found that incidentally discovered Chiaris, and these were children that presented with MR imaging for some other cause, whether it was a car accident or for some other imaging indication, that 85% are unlikely to require any intervention, especially in the absence of syringomyelia, and that really at the end, 16% had surgery and 10% occurred within the 6 months of diagnosis, and that there is a small subset of children that will undergo de novo formation of a syrinx and progressive neurological symptoms during this follow-up period that required intervention, and that syringomyelia was probably the biggest was the driving force for surgical intervention, and the children that did not have syringomyelia were unlikely to require any intervention. So as I progress, when does a Chiari become a surgical disease? And really, an international survey found that if they're symptomatic, if the tonsillar descent was 12 millimeters or greater, if there was loss of CSF at the cranial vertebral junction, and if there was the appearance of a syrinx. And can any Chiari be treated by cervical medullary decompression alone? And I think, fortunately, Dr. Brockmeyer is going to cover complex Chiari because those are a formidable challenge with increased morbidity, and a simple Chiari surgery may not suffice. In these cases, surgery needs to be tailored to the etiology rather than to the Chiari decompression. So I think the most widely accepted surgical approach is to perform a craniocervical or craniovertebral decompression with or without a dural graft. And that it should be emphasized that the craniectomy should be small to avoid downward migration of the hindbrain into the craniectomy, and that the slumping phenomena of the hindbrain is a known risk. So I think the goal is really to achieve a reconstruction or reconstitution of the cisterna magna to improve CSF flow with the hopes of improving the syrinx size and allow the cranial ascent of the hindbrain on future MRIs. So, I think in terms of the treatment of Chiari malformations, and this is not an exhaustive list. I mean, I list, I think, 9 different approaches, but I can reassure you that these aren't the only 9 approaches. I think there's a little over 50 members here in the audience participating. There's probably 50 different ways to do a Chiari malformation. I think the standard is posterior fossa decompression, whether one opens the dura or doesn't open the dura. Open the dura, don't touch the arachnoid. Open the dura. Um, uh, Open the arachnoid, resect the tonsils, coagulate tonsils, duroplasty, no duroplasty. The question of whether or not one should, do a C1 laminectomy. Some have also advocated for C1, partial C2. Others advocate no foramen magnum decompression. Just do a resection of the posterior arch of C1, open the dura and resect the tonsils with a duroplasty. So there are many different variations, or whether you call them variations or controversy regarding the management of the Chiari. But I think really the key is, performing the procedure and minimizing complications. And many of the complications have been, are supported in the literature by as a result of opening the dura, doing a large occipital as well as a C1 and a C2 decompression. And then there's some increased complications with coagulating the the cerebellar tonsils. I think this is a large series, although it is both pediatric and adult, from George Klemkamp. And really what they found was that that the morbidity associated with can be as high as somewhere between 2 to 5%, and that really opening the dura and manipulation led to an increased complication as compared to not opening the dura. And I think this is supported more recently by the Picori study looking at posterior fossa decompression with and without duroplasty. And what they found that although the risk of reoperation was higher when a duroplasty was not completed, just posterior fossa decompression, bone only decompression, when a posterior fossa decompression with duroplasty was performed, there's clearly a greater risk of cerebral spinal fluid related complications, as high as almost 20% if one opens the dura as not opening the dura. And I think what's interesting is, as I was preparing for this, came across this paper, which compares a suboccipital craniectomy versus a cranioplasty. And again, this is both really a large series of 64 patients that both pediatric and adult. And what they found was that although the craniectomy group had a larger increase in the subarachnoid spaces compared to the cranioplasty. The results of syrinxes in their series of syrinxes, the reduction in syrinx size was smaller, was similar. And the only finding that they found was really that the cranioplasty group on average there's significant statistical significance in the cost, almost doubling of the cranioplasty versus the craniectomy group. And you can see their treatment algorithm and their results there. The next question I think, is the question that Dr. Christian brought up is the series of children that may have syndromic craniosynostosis with a Chiari. And in this paper, about 13 years ago, really what they felt that in children with syndromic craniosynostosis and Chiari, probably the initial strategy should be on the cranial vault or the craniosynostosis, followed by a period of waiting and radiographic surveillance. And this was again similar to the Birmingham group that looked at their series of posterior calvalleal vault expansion using distraction osteogenesis. And Naren, I think you might have been involved in this group as well that advocated really for posterior cranial vault distraction in their series of both syndromic and non-syndromic children that had craniosynostosis and a Chiari malformation, and that the posterior distraction surgery both was a treatment for the raised intracranial pressures as well as a good treatment for their Chiari malformation in these children. And then, in terms of more controversy, is really, I think it's Professor Toole's paper about 7 years ago that really felt that, and I think it's the first time that we read about the Chiari formation rather than a malformation, where he identified three types of instability in 33 patients that had Chiari malformations, and the treatment was an allantoaxial fixation, and it treated both their instability as well as their Chiari malformation. And I will, address this with Professor. And you can see the type 1 there, anterior versus the posterior, and the type 3 where there's really normal alignment, no evidence of instability, but a Chiari malformation. And what he found was, in their series, is highly successful not to do Chiari decompression surgery, but the allantoaxial fixation, which resolved both the Chiari, their instability, and the presence of a syrinx if there was one. The other question is, I think some controversies, is really the use of evoked potentials during a Chiari surgery. In my practice, I don't routinely use neurophysiological monitoring, although this paper in 2017 found that they did find that there were some electrophysiological changes that were evident during the operation. However, they did not add any clinical information in patients during the operation during the surgical removal. And this more recent paper found that really that there was it was not a useful adjunct for surgery given their retrospective analysis of over 100 patients, and really did add a cost to the surgery and that really that they advocated that the routine use of neuromonitoring should not be used during surgery. So I think, to just as I begin to finish up, I really just want to talk about complications, the CSF leak, pseudomeningocele. We heard about hydrocephalus, meningitis, cerebellosis, instability, and paraplegia. I think from the PCORI study, the Park Reeves Research Consortium, really when they looked at their approach for the Chiari-1 malformation, and they looked at both whether an autograft was used, and they looked at their autografts was the pericranium in probably 95% of their autografts versus a non-autologous or allograft, where they looked at bovine collagen, a pericardium, an allograft, or a synthetic material. And what they did find was that there was that really the complication rates are similar when one does a duroplasty. However, there was a slight increased incidence of pseudomeningocele and aseptic or chemical meningitis when a non-autologous grafts were used, whether it was a bovine pericardium or the bovine collagen. Clearly, that was the highest incidence and the complications that was associated with it. And you can see in their tables the results of the individuals. So I think clearly, the question then came up in another study that looked at the duroplasty versus a non-duroplasty posterior fossa decompression. And what they did find was that there's really no differences between the groups for postoperative complications beyond the 6 months of surgery. However, the posterior fossa decompression group without duroplasty were more likely to require revision surgery. I think it was 18% versus 8%, and that the duroplasty group had a greater improvement in headaches and back pain as compared to the non-duroplasty group. But there's really no differences in whether in neurological examination and in terms of that. And I think you can see, in their tables, the incidences of complications was relatively similar in both groups, and I apologize for that. And however, there was a difference in the operating times and really the length of stay in the hospital. Your posterior fossa decompression with that duroplasty were tended to be discharged 1 or 2 days earlier than a duroplasty group there, and that really there's no time for revision. I think the question comes up of the headaches, and I know that came out of the Park Reeves group. We had looked at this when I was in Baltimore, and clear, I think what we did find was that that headache was more likely to recur than objective cranial nerve or brainstem symptoms following surgery for their Chiari. And really, what we did find was that the increasing length of preoperative headaches and vertigo, as well as frontal headaches, were more likely to result in recurrence of their symptoms as compared to other findings. And I think this was confirmed by the Boston Children's Group this couple months ago. And what they found was that really, regardless of the procedure, that in their study, they found no difference in the headache outcomes in really the children that had the classic or the fleeting headaches, but in children that had atypical headaches, they're more likely to have a recurrence of their symptoms or a lack of improvement of their symptoms following Chiari surgery. Decompression surgery as compared to the fleeting headaches that Dr. Lindbergh. So I think if we just, as I close, bring it all together, I think, if one has confirmed radiographic Chiari, if they're asymptomatic, if there's a syrinx, I think they should recommend the circummedullary decompression in the group that has no syrinx, really observation. In the patients that are symptomatic, is there presence of hydrocephalus? I would consider a CSF diversion, ETV shunt. If there's no hydrocephalus, consider the circummedullary decompression. And if in terms of whether a duroplasty or a non-duroplasty, I will defer to the individual surgeon's preference. And if they become have recurrent or new symptoms or the presence or absence or the presence of lack of resolution of the syrinx or development of syrinx, really consider re-exploration with a duroplasty. I think there's a very small subgroup that may require a syringo-subarachnoid stent. If there's ventral decompression, I think these are complex and require reduction or invagination fixation. And I'm going to defer Dr. Brockmeyer's lecture, craniosynostosis. Heard little about this here as well as earlier about the cranial vault expansion. So going back as I close with my young girl that presented with the Chiari and that cervical syrinx. I did advocate for a decompression. She underwent posterior fossa decompression, C1 laminectomy without a duroplasty, did not open the dura. And then she was discharged home on post-op day 1. And the question was the timing of repeat imaging. I tend to repeat the images. I will get a baseline at 3 months after surgery, although I'm not looking for the syrinx to decrease in size. And then the next study is usually at the 12-month mark. And at her annual visit, her annual return visit, this was the results of her decompression surgery. You can see that there was some improvement in the shape of the tonsils, a little space, CSF space around the cerebellar tonsils, and a dramatic reduction in the syrinx. So hopefully, I think, as I conclude, clearly the ventriculomegaly, the hindbrain progression, the calvalular augmentation, and then the treatment of, the syrinx, and whether or not it should be treated or not, and what is the best treatment for this. So I do want, Naren, thank you for having me invited to speak today. And I'd also, I know there's going to be some controversies following this lecture, and I am looking forward to that lively discussion. Thank you so much.
Thank you very much, Dr. Jallo, on this very an excellent overview of the controversies and thought and provoking our thoughts. And may I please invite Dr. Llewellyn, Professor Llewellyn Padayachy, to comment and ask questions first. Thank you, Professor Padayachy.
Thanks so much, Naren, and thanks, George. As usual, it was just a fantastic, insightful talk. Perhaps just a question. So you mentioned motor-evoked potentials, in that context of adjuncts and, for positioning. We've done a few cases now where we've seen the motor-evoked potentials change just on positioning, so flexion of the neck. In fact, in one case, we actually saw it kind of disappear. The meaning of that is really difficult. But the context of adjuncts, so the use particularly, something I've been quite keen on, ultrasound or some sort of intraoperative, quality check mechanism to decide whether the bony decompression alone is enough or, whether you open the dura. So we followed a kind of a treatment algorithm where we do cine flow CSF before, and if there's no CSF flow around the craniovertebral junction, then the ultrasound before thinking about opening the dura, if you see some flow with the power Doppler, is useful. I mean, any thoughts, or do you use that, or any thoughts on whether we should, or if it's useful or not, George?
Yeah, wonderful question. I do use the ultrasound, but there are times where I haven't found it helpful. In my mind, I've made a decision beforehand if I'm going to go in and just do a bone only, or I'm going to do the decompression with a duroplasty. I use the ultrasound as an adjunct, and I will say it hasn't changed what my preoperative approach was. in those children. But again, that's it might be just unique to my practice. Along those lines, I know there are certain groups that use intraoperative MRI for all their Chiari decompression surgeries, where they do the bone-only decompression, do an MRI, and then modify their approach based on the intraoperative MRI. And then along neuromonitoring, I do, I don't use it in the routine Chiaris, but if there is evidence of instability or some anterior compression, or really, for my skeletal achondroplasia, where I'm doing a decompressive surgery, I routinely use neuromonitoring for those.
No, thanks, George. Thanks so much.
Thank you, Professor Padayachy. We have also the other faculty is Professor Ricardo Santos de Oliveira from Sao Paulo. Professor Ricardo, do you have any questions or comments for Dr. Jallo? Thank you.
So, thank you, Naren. Thank you so much. And thank you, George, for this excellent talk. I think that Chiari 1 is the perfect topic to discuss controversy. It's a really, really amazing topic. Yeah, I think that you explore some very interesting points as in terms of terminology, clinical presentation, posterior fossa decompression, dura or open the dura or not open the dura, and finally, the primary and secondary Chiari. Yes, these are very exciting topics, but I'd like to ask to know what your opinion about the very controversial surgery, the filon terminal section. So, what is your opinion about it?
Carter, thank you. I must admit, I think that's extremely controversial. In my experience, I've seen of several hundred Chiaris, I've only seen a tight phylum in 1 or 2 cases. So, I will say my experience is very limited, and I am not. I know some will do the Chiari decompression. Then, if that doesn't improve, then they will cut the tight phylum. In my opinion, if there is a tight phylum, I would advocate to treat that first before we're doing the decompression surgery.
Yeah, I agree with you. But here in Brazil, we have some legal problems with this. Fortunately, I see some patients that went to other countries to do this kind of surgery. Of course, without a confirmation of tight phylum, it just a suspicion of Chiari, and then this surgery became kind of a miracle to treat Chiari. And we know you presented extremely well. Chiari and the other speakers presented some very interesting points. Chiari is a very how can I say? It's a very individual situation, and then you need to tailor almost selectively in terms of patients. So I think that I agree with you. Maybe I did 1 or 2 surgeries in real tight phylum, but not as some people advocated to treat this extremely complex disease. So thank you, George. Thank you, Nari, for this excellent presentation today about Chiari.
Thank you very much, Professor Ricardo Santos de Oliveira. Dr. Jallo, I have one question for you. You mentioned about asymptomatic patients with syrinx, and if I read your slide correctly, that your recommendation was for surgery Am I right? And would you observe a few times before surgery? Would you look at to see whether if the patient is asymptomatic and if the syringe was not enlarging, whether would you hold on? That's one question. And the second question is, if a patient with Chiari who's asymptomatic kid, what's your advice for playing any sort of sports, let alone contact sports? So 2 questions. Thanks.
Naren, I think that's great questions. I'm going to take the second first. I don't have I don't put any restrictions on my straightforward Chiaris. Again, just Chiari, no basilar invagination, no other conditions. I don't place restrictions. If again, if they want to play sports, they can play sports. I may educate them about avoiding contact sports, but I can tell you I've had I had 2 or 3 high school football players with Chiari, and their only symptom, no syrinx, Chiari, only symptom was headaches, classic Valsalva-induced headaches when they were in the weight room. I educated them. I said, you are asymptomatic. If you don't do sports, maybe you shouldn't do any heavy weightlifting. But they continued to play football and really saw no complications associated with it. And I would, 2 of the 3 actually had improvement of their Chiari as I followed them over time. The other question is the asymptomatic Chiari with syringomyelia. If it's truly syringomyelia, not a dilated central canal, because that's a lot of my practice is really just a small dilated central canal, some cerebral ectopia, go see the neurosurgeon. But if they do have a syringomyelia and they're asymptomatic from their Chiari, I'd still advocate for surgery on those patients.
Thank you, Dr. Jallo. I think with controversies in Chiari, I think we can just have one whole day on one aspect of controversy. There are a few questions, Dr. Jallo, for want of a time. May I please ask you to have a look at them? I just want to acknowledge that we talked about bony decompression for Chiari. Certainly, the first paper on bony decompression for Chiari was from Professor Atul Goel in the 1990s. So Dr. Atul Goel has strings of first, and so it's important to acknowledge that. I'm just going to go to the next lecture. Thank you very much, Dr. Jallo.